I'm going to focus entirely on the paper we wrote. We spent a lot of time writing this paper over a number of years. It's a very simple paper looking at it now, but we went through a lot of internal reviews before we submitted it to try to get everything clear as possible and to not make mistakes that we might regret afterwards. This is the title of the paper: National Trends in the Frequency of Bladder Catheterization and Physician-Diagnosed Catheter-Associated Urinary Tract Infections, Results from the Medicare Patient Safety Monitoring System. And it's been published recently in the American Journal of Infection Control. And anybody that's on the line, or your colleagues, if you want a full text copy of the paper, I can send you a full text copy. Just send me an email at that address there. So one of the things that you might think that the title looks a little funny, why do we say physician diagnosed CAUTI? It's because in our definition of CAUTI that we use in the Medicare Patient Safety Monitoring System, we don't have an extra test once a CAUTI is diagnosed by the physician. So we don't go back and look in the record to see if once the physician has said this patient has a UTI after having been catheterized, we don't go in and see if the laboratory test confirmed that there were sufficient CFUs to justify considering that a bona fide UTI. So that's an interesting aspect of the CAUTI, the MPSMS definition. And in discussions with CDC over the years, we agreed to start calling our measure physician diagnosed CAUTI because it's not having the same sort of level of evidence that it was a true UTI. So the pros of this definition, you can see them there, are that the patient was catheterized and the physician refers to this as a UTI, tells the patient they have a UTI, treats it as a UTI, gives antibiotics, that's part of the measure. And the definition has been in place for a number of years. My colleague, Dr. Matursky, actually reminded me that it was changed in 2006, but this still gives us 10 years of data with basically the same definition. And so that makes it apples to apples comparisons relatively easy and good. The cons of this definition is that some people might say, well, you haven't really proven that it's a UTI. You haven't really confirmed that this person's urinary tract was infected with bacteria or some other microorganism that would cause a UTI. And another con is that the denominator of the discharges or the patients catheterized, depending on how you look at it, is hard to compare sometimes with some of the more common measures out there, such as ones that are done by catheter days. And Kevin described earlier what some of the downsides of going by catheter days or line days are. So this is the abstract to our paper. And I thought I would just go over this quickly because it's really a nice way to simplify the whole project. And then I'll show you some data highlighted from some charts that we put together. So the question was, could we see that bladder catheterization and catheter-associated urinary tract infection rates have gone down since the implementation of public reporting in 2011, which was sort of an intervention to try to influence the rates of these things. So there's bladder catheterization. You wouldn't want that to be a zero rate thing. You would like the catheter-associated UTI to be a zero rate, but you wouldn't aim towards getting rid of all bladder catheterization, but you would hope that it would go down because you would imagine that there's some degree of bladder catheterization that's unnecessary, even if it's not precisely known what that is. You would hope if you put an intervention, you might be able to bring the rates down because there's sort of an unnecessary rate that's mixed in with the necessary cases. So what we did was we looked at the data from our system, which is a chart abstraction system, where we have typically about 20,000 charts a year to look at. And they're typically in four major groups that we used in this study: the heart failure, AMI, pneumonia, and major surgery, as identified by the SCIP program, which is the Surgical Care Improvement Project, which defines a series of different surgical procedures that are used every year in the same collection of surgical cases so that it's not a changing number of cases or types of cases every year. And we looked at the data from 2009 to 2014 because our data started in 2009 with this sample. We have data from previous years, but there was a different sample. And we had the data through 2014 because that's when we started writing the paper after the 2014 data became available after we analyzed it and had it in 2015. So the results were basically that we saw, you can see here, the catheterization frequency declined significantly in the AMI, heart failure, and surgical patients. In pneumonia patients, we didn't see any significant change over time. It was a non-significant increase of 1.1%. And then the risk-adjusted CAUTI rate among the AMI patients decreased 9.7% per year during this period, and surgical had a decrease of 9.1% per year. And we didn't see significant changes in the other two patient groups. The heart failure patient group had a decline, but it wasn't significant. It crossed zero. So then overall, we could say that the burden of CAUTI among surgical patients was also higher than the other groups, which is an important point because they're getting catheterized at such a higher rate. So the conclusions were that we saw statistically significant declines in observed bladder catheterization frequency and an adjusted CAUTI frequency in some patient populations. So that's kind of a vague conclusion, but we saw it, I think, in most populations. And you can take a look at the next couple of slides and see what you think. So this is a complicated table with a lot of different numbers in it. Let me quickly go over. There's 3 different numbers. So let's just look at them for the AMI cases. So the first row shows patients catheterized out of all hospital patients in that group. So for example, AMI, 32% of the patients were catheterized in 2009, 997 out of 3,075. And then how many of them had a CAUTI? 52. And that's 5.2% of the catheterized patients, 52 out of 997. And then, like Kevin was saying earlier, we're also interested in what percentage of hospitalized patients in this group had a CAUTI, because one of the interventions to reduce CAUTIs is to introduce less catheters. If you don't get a catheter, you can't get a catheter-associated UTI. So the third number there, the percent of hospitalized patients, is simply the previous two numbers multiplied by each other. 5.2% times 32% is 1.7%, and down the line. So you'll see for AMI, the percent of hospitalized patients with a CAUTI went from 1.7% in 2009 to 2.8% in 2014. And where did that improvement come from? It came from two things. It came from the percent of patients being catheterized going down, as you can see there, from around 32% to around 26% in the last year. And then the number of patients who have a CAUTI among those catheterized also went down. In this group, it went down from 5.2 down to 3.3 in the final year, but it went down pretty consistently. The last year was especially low, but you get the idea. So I'm not going to go through all these different numbers in this table. I'm going to show it to you in a couple of charts to show you what I think the main points are. So in this chart, you see the percent of hospitalized patients with a CAUTI. So first one is the major surgery patients at the top of the chart there. And you see that's the purple line. And it went from about 2.1% to about 1.4%. So that's about a 1/3 reduction overall. And then the heart failure, you can see the first 3 years a little high, then the second 3 years a little low, but it's not that clear of a signal. The AMI is kind of like the surgery in that it's an ongoing downward trend. And the pneumonia looks like nothing happened. Went up a little, went down a little, went up a little, went down a little. We didn't see much trend there. Also, you can see the pneumonia has the lowest rate overall. Now, one thing that I want to mention here is that we used a number like this one, although computed a little bit differently, in the Partnership for Patients, which was a major federal program that's been running the last few years, but was especially funded from 2011 through 2014 in the production of a national HAC rate, HAC being the rate of hospital-acquired conditions. And we've put that online on the AHRQ website, and there's a link there. It covers the period 2010 to 2015. And we have our own methods and discussions on those data on that website. Now this chart is one that I prepared for this presentation after doing an internal presentation to some colleagues a couple of weeks ago. This is the same data minus 2009, just 2010 to 2014. And we didn't publish it this way because it would have seemed like we were cherry picking the data. We didn't want to do that. But my colleague did say, remember, Noel, in 2009, the data really did need the risk adjustment more than the other years because the sample was slightly different in 2009. We only had 3/4 of data. We didn't have 4/4 of data just for internal bureaucratic reasons. We didn't have 4/4 of funding or programmatic resources to get it done back then. And then the way the hospitals were selected and the cases were selected was a little bit different than those following 5 years, and that there was more data from smaller hospitals. And this data is not risk adjusted. So this is a little bit of an interesting chart because when you look at 2010 2014, these trends are even more convincing for the AMI, the major surgery, and the heart failure. The pneumonia still doesn't show anything really, if you ask me. Oh, let me get one more thing before we go to the risk adjusted data. This is additional data that I thought was interesting, and my colleague, Dr. Matursky, who's the first author on this paper, recommended providing this data as well. So this shows what Kevin was talking about, the efforts to reduce the catheterization rates. Now, this is nationwide data. This is not data for some demonstration project or 10 hospitals that put together a consortium and tried to figure out how to make it better and really made a major change. This is representative of the whole United States. I like to think about it sort of as the years where we got about 30,000 charts. Some years we only got around 20,000, but the years where we get around 30,000 charts, there's 30,000 charts out of about 30 million charts. So it's about 1 in 1,000 charts for the whole country. And you can see here that based on our data, it looks like for every one of these groups, more or less, the pneumonia is not really showing much of a trend, but the other three, we're seeing a reduction of about 5% in the absolute reduction. Now, of course, that 5% is a big difference in relative reduction for AMI and heart failure. For the major surgery, it's a lesser of a relative reduction. It's 5 out of 85, whereas for heart failure or AMI, it's 5 out of 30, so to speak, or 6 out of 30. So you get the idea of what the situation is with those. And you can see that obviously for major surgery, even though we're trying to reduce it, there's a level at which you probably can't get beneath. But we don't know what that is yet, but I wouldn't be surprised if it's not much better than you couldn't get much below the 80 we're showing there, unless there's some different technology that comes along and people start using that, like condom catheters, for example. Okay, now this is the risk-adjusted data, and this is the data we have in the abstract. The AMI and the SCIP, which is the major surgery group, had large and statistically significant reductions just looking at the CAUTI rate, which is the rate of CAUTI among catheterized patients, 9% a year approximately for both of those groups. And you can see the 95% confidence intervals there. As I mentioned earlier, the heart failure didn't pass the significance test, and the pneumonia data, the reduction was not even close to being significant. These are my co-authors of the paper. Dr. Matursky is the first author. He's the corresponding author. So if you have any questions, feel free to contact him. You can contact me too, but he's the expert beyond me in this area. You can see his email address there. And that's it. The paper's online. You can see the website there. You can send me a full text request. And some of the data that we've put out representing the whole nation is at this website that I mentioned earlier.